Hello students, welcome to EPG Pathshala. I am Satwanti Kapoor from Anthropology Department of Delhi University. Today I am going to speak on the module Lifestyle Diseases and Quality of Life from the paper Applied Anthropology. This module has certain learning objectives, means at the end of this module you will be able to understand the concept of lifestyle disease, the concept of quality of life and its assessment, the impact of quality of life on lifestyle disease, the impact of lifestyle disease on quality of life, the measure taken to control lifestyle diseases. First of all, let us discuss briefly on the concept of lifestyle diseases. Now, what are lifestyle diseases? Lifestyle disease is a broader term of those non-communicable diseases, NCDs, whose occurrence is primarily based on the daily habits of people and which are results of an inappropriate relationship of people with their environment. Lifestyle diseases are also often referred to as chronic disease because the disease require long-term treatment and may even require a lifelong treatment. Lifestyle disease can also be defined as diseases linked with the way people live their life. Lifestyle diseases are found to be increasing in frequency as countries become more industrialized and people live longer. It used to be a disease of the industrialized countries and so-called Western diseases or disease of affluence. However, it is spreading fast in the developing countries as well. There are numerous lifestyle diseases and are increasing with changing time and with development in all the fields of life. Some of the lifestyle diseases are Alzheimer's disease, arthritis, atherosclerosis, asthma, cancer, chronic liver disease or cirrhosis, chronic obstructive pulmonary disease which is called as COPD, type 2 diabetes, heart disease, metabolic syndrome, chronic renal failure, osteoporosis, stroke, depression and obesity. In a way, lifestyle diseases are related to the change in way of living which can occur due to varying causes from occupational lifestyle, habitual lifestyle to leisure lifestyle. The emergence of lifestyle disease has gained more attention due to its impact on the health of the individual as well as to the community. That is why lifestyle diseases are often referred to as modern epidemic. Lifestyle diseases like hypertension, diabetes mellitus, dyslipidemia and overweight obesity are major risk factors for the development of cardiovascular disease which are called CVD. If one considers the global picture, developing countries show high prevalence of lifestyle diseases. Many studies have reported that prevalence of these diseases has reached alarming proportions among Indians in the recent years due to rapid economic development and increasing westernization of lifestyle in the past few decades, including overweight and obesity in recent years, even though undernutrition continues to be an important public health issue even in this 21st century. There is paucity of epidemiological data on the overall prevalence of lifestyle disease in India because of the following reasons. 1. The country is huge with very diverse population that has different social and cultural characteristics. 2. Even today there is inadequate access to healthcare institutions for many rural communities. And 3. Reliance on indigenous healthcare systems such as Ayurveda, Unani and Siddha by many individuals of the country. Lifestyle diseases are also termed as chronic disease like cardiovascular disease, mental health disorder, diabetes and cancer, which are the leading cause of death in India, and a pronounced increase is projected in their contribution to the burden of disease during the next 2.5 decades. Most chronic diseases which are the outcome of lifestyle factors and earlier termed as the disease of the industrialized countries are equally prevalent in poor and rural population and often occur together. Now let us see what are the modifiable risk factors of lifestyle disease. There are many risk factors associated with lifestyle diseases. However, some of the risk factors are modifiable, means they can be modified. The modifiable behaviors such as tobacco use, physical inactivity, unhealthy diet and the harmful use of alcohol all increase the risk of NCDs. Some account of The impact of uncontrolled modifiable behavior are as follows. Tobacco accounts for 7.2 million deaths every year, including those from passive smoking, and is projected to increase markedly over the coming years, GBD 2015. 4.5 million annual deaths have been attributed to excess salt sodium intake, GBD 2015. More than half of the 3.3 million annual deaths attributable to alcohol use are from NCDs, including cancer. 1.6 million deaths annually can be attributed to insufficient physical activity, GBD 2015. The metabolic risk factors contribute to 4 key metabolic changes that increase the risk of NCDs, and they are raised blood pressure, overweight, obesity, hyperglycemia, that is high blood glucose level, and hyperlipidemia, that is high level of fat in the blood. Culture and lifestyle diseases. Lifestyle diseases, which are often referred to as chronic disease or non-communicable disease, NCDs, usually emerge in middle ages after long exposure to an unhealthy lifestyle involving tobacco use, lack of regular physical exercise, and consumption of diet rich in highly saturated fat, sugar, salt, etc. These factors in the postmodern concept is typified by fast foods. Chronic conditions are often incorrectly considered to have limited impact on the burden of disease in India and in most of the developing countries where there is a cultural context to being fat and not thin. For example, in many sub-Saharan African countries, an increased level of body fat is associated with beauty, prosperity, health and prestige, despite its negative impact on health. Thinness, in contrast, is perceived to be a sign of ill health or poverty and is something to be feared and avoided, particularly in recent years when it has been associated with AIDS. Taylor et al. 1999. In many disadvantaged communities in South Africa, food is highly valued because food scarcity or food security has not always been ensured. Researchers found it to be socially unacceptable for an individual to refuse to eat food that was offered to them. Move et al. 1999. The concept of eat as much as you can, for tomorrow you may die, is practiced in these communities. They are unaware of the fact that the excess dietary carbohydrates or fat is stored or accumulated as fat. Brown and Conner 1987 also reported that the majority of the less developed regions had or still have ideals of feminine beauty that includes plumpness, which is consistent with the hypothesis that fat stored function as a cushion against food storage during pregnancy and lactation. Studies have shown that black women in South Africa also do not perceive being overweight or obese as a health risk. Nudlow and Roos 1999. In these countries, thin is associated with poverty. The current burden of chronic diseases reflect the cumulative effect of unhealthy lifestyle and the resulting risk factors over the lifespan of people. Some of these influences are present before a child is born. As to be fat depends not only on the behavioral and environmental factor but also on the genetic makeup of the individuals. Mehtabji et al. 1992 found salt sensitivity measured by the blood pressure response on salt loading in 46.2% of the subjects studied in Tanzania. A high intake of sodium is common in sub-Saharan Africa as it is used to preserve food or to make food tastier. For example, Capesio et al. 2000 described the diet in Ghana as consisting mostly of unprocessed food and highly salted fish and meat. Substantial amount of salt are added to food while cooking, and monosodium glutamate based flavoring cubes or salt are widely used to give food a taste. In addition to a high salt intake, people in sub-Saharan Africa frequently eat little fruit and vegetables, resulting in low potassium intake. In a study conducted among the traditional and conservative Bania Agarwal community, preferring their own traditional diet, which is generally rich in oil and fat, predisposing this community to obesity and other cardiovascular risk factors. It has been found that the blood pressure of sons showed a significantly higher correlation with their parents. than did daughters. Due to this society preference for male, boys are likely to enjoy more of the family's resources and pampering than girls. This results in poor eating habits, making them more prone to cardiovascular problems similar to their parents. Gupta and Kapoor, 2013. Let us see what is quality of life. According to the World Health Organization (WHO), quality of life is defined as the living condition associated with the corresponding goal, expectations, standards and concerns of each individual living in different cultural systems. WHO 1993. The quality of life as a new health indicator is not only concerned about how long people can survive but more concerned about how well people live. The first measurement of the quality of life is the United States National Measurement Report in 1960 by the United States Dwight D. Eisenhower National Goal Committee, Spitzer, 1987. After the 1980s, the assessment of the quality of life in the allocation of health resources, the choice of patient individuals, treatments, the comparison of various treatments in clinical trial and quality of life measurement in healthy people has been widely applied. The Center for Disease Control and Prevention (CDC) defines quality of life HRQoL as a broad multi-dimensional concept that usually includes subjective evaluation of both positive and negative aspects of life. What makes it challenging to measure is that although the term quality of life has a meaning for nearly everyone and every academic discipline, but individuals and groups may define it differently. Health is one of the important domains of overall quality of life. Though there are different domains of quality of life like jobs, housing, schools, the neighborhood, aspects of culture, value and spiritual that adds to the complexity of its measurement. Nevertheless, researchers have developed useful techniques that have helped to conceptualize and qualify those manifold domains and how they relate to each other. Now let us discuss about the domain of health related quality of life, HRQoL. Health related quality of life, HRQoL, refers to the physical, emotional and social impact of disease and treatments and is distinct from physiological measures of disease. The concept of health related quality of life, HRQoL, and its determinants have unfolded since the year 1980 to include those facets of overall quality of life that can be clearly shown to affect health, which may be physical or mental. The SF-36 short form health survey is developed as an indicator of overall health status. At the individual level, HRQoL includes physical and mental health perceptions, example energy level, mood, etc., and their correlates including health risks and conditions, functional status, social support and socioeconomic status. At the community level, HRQoL includes community level resources, conditions, policies and practices that influence a population's health perception and functional status. On the basis of a synthesis of the scientific literature and advice from its public health partners, CDC has defined HRQoL as an individual's or group's perceived physical and mental health over time. The HRQoL was constructed in such a way to enable health agency to legitimately address broader areas of healthy public policy around a common theme in collaboration with a wider circle of health partners including social service agencies, community planners and business groups. HRQoL questions have become an important component of public health surveillance. Anthropological field surveys are generally considered valid indicators of unmet needs and intervention outcome. Self-assessed health status is also a more powerful predictor of mortality and morbidity than many objective measures of health. HRQoL measures make it possible to demonstrate scientifically the impact of health on quality of life, going well beyond an old paradigm that was limited to what can be seen under a microscope or felt with a stethoscope. Why is it important to track HRQoL? Quality of life is important to everyone as it adds active years to the life of an individual. Although the World Health Organization, which is WHO, defined health in its broader sense in its 1948 constitution as a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. Health has traditionally been measured narrowly and from a deficit perspective, often using measures of morbidity or mortality alone. But health is a multidimensional construct that includes physical, mental and social domains. As medical and public health advances have led to cures and better treatments of existing disease and delayed mortality, it was logical that those who measure health outcomes would begin to assess the population's health not only on the basis of saving lives but also in terms of improving the quality of life of the people. It can also be used for policymakers, health planners to devise strategies for prevention of many communicable as well as non-communicable diseases. Focusing on HRQoL as an outcome can bridge boundaries between disciplines and between social, mental and medical services. Several recent federal policy changes underscore the need for measuring HRQoL to supplement public health's traditional measures of morbidity and mortality. Healthy People 2000-2010 identified quality of life improvement as a central public health goal. Some of the importance of measuring HRQoL are highlighted below. HRQoL is related to both self-reported chronic disease, which are diabetes, breast cancer, arthritis and hypertension, and their risk factors, body mass index, physical inactivity and smoking status, etc. So it provides data on overall health of an individual. Measuring HRQoL can help determine the burden of preventable diseases, injuries and disabilities, and can provide valuable new insight into the relationship between HRQoL and risk factors. Measuring HRQoL will help monitor progress in achieving the nation's health objective. Analysis of HRQoL surveillance data can identify subgroups with relatively poor perceived health and help to guide interventions to improve their situations and avert more serious consequences. Interpretations and publications of these data can help identify needs for health policies and legislations, help to allocate resources based on unmet needs, guide the development of strategies, plans, and monitor the effectiveness of broad community interventions. In this slide, we will learn about the impact of lifestyle diseases. Obesity to a great extent increases the risk for conditions such as type 2 diabetes, hypertension, dyslipidemia, gallbladder disease, sleep apnea, osteoarthritis and lower back pain. Further, coronary artery disease and some cancers which reduces life expectancy are found to be the outcome of obesity. The factors that increase blood pressure such as obesity, high alcohol and salt intake are called hypertensinogenic factors. Some of these factors have inherited behavioral and environmental components. Vikrant and Tiwari 2001. Central obesity or abdominal obesity has been shown to be associated with metabolic syndrome. The key feature of this condition are raised blood pressure, raised insulin and triglyceride levels, reduced high density lipoprotein HDL, cholesterol level and insulin resistance. The association between hypertension and obesity has been well documented in many countries. Worldwide, Indo-Asian people are among the populations at highest risk for cardiovascular disease. Zafar 2005. The increasing prevalence of overweight and obese population globally is associated with urbanization, changing dietary pattern and less physical activity, and a rise in socioeconomic status. In 2014, more than 1.9 billion adults 18 years and older were overweight. Of those, over 600 million were obese. Cardiovascular disease, that is CVD, are a major cause of morbidity and mortality worldwide. Hypertension is one of their most prevalent risk factors. Globally, they account for approximately 17 million deaths, and by the year 2030 is projected to be the leading cause of death worldwide. Murray and Lopez 1997, Lopez et al. 2006. High blood pressure is a major risk factor for heart attack and stroke. Cannell 1996. It also contributes to renal disease and blindness. The main risk factors for hypertension include heredity, age, ethnicity, obesity, stress, sedentary lifestyle, alcohol consumption, gender, use of contraceptives, and high sodium intake. Simonetti et al. 2002. Earlier surveys showed that the lowest prevalence of hypertension occurred in the poorest African countries, and as affluence increased, the prevalence increased. The survey also revealed that hypertension was more common in urban than in rural setting in the region. Nisinen et al. 1988. The Kenyan migration study of Polter et al. 1990 was the first to show that migration of people from traditional rural village on the northern shores of Lake Victoria to the urban setting of Nairobi was associated with an increase in blood pressure. Some dietary factors are related to hypertension, including increased salt, that is sodium intake, and a decrease in fruit and vegetable potassium consumption. A higher intake of alcohol products, particularly by men, also plays a pivotal role. The data on the association between high salt or sodium chloride intake and hypertension in black people from Africa has been summarized by Siddharth 1996 and suggests that black people have a transport mechanism of high sodium retention and a low renin activity. Since the past few years, stress has been postulated to be an important factor in the pathogenesis and development of lifestyle diseases, which further leads to the development and acceleration of atherosclerosis. Stress may be caused due to many factors like family pressure, work pressure, health, etc. Dyslipidemia is defined as a clinically significant alteration of the naturally occurring blood lipids and lipoproteins predisposing to cardiovascular disease and other chronic diseases. Berger and Marais 2000. A particularly atherosclerotic combination of lipid and other risk factor is referred to as the metabolic syndrome and leads to premature coronary heart disease. This syndrome consists of high level of blood triglyceride, low level of HDL, cholesterol, and small dense LDL particles. It is also associated with type 2 diabetes, hypertension, abdominal obesity, insulin resistance, and physical inactivity. Dyslipidemia aggravates the quality of life of people with hypertension. Impact of lifestyle diseases on quality of life, QoL. Several studies have shown that living with a chronic condition significantly reduces quality of life, and having multiple chronic conditions reduces QoL. Even further, people living unhealthy lifestyle are at risk of suffering from different types of chronic diseases which may occur in the early part or in the late part of the human life. The most common degenerative diseases leading to reduced quality of life are cancer, hypertension, osteoporosis, and diabetes mellitus. 14 et al. 2006. Regardless of the condition type, patient's QoL is adversely affected by chronic illness. Stewart et al. 1989. This is an important consideration in the management of asymptomatic conditions such as hypertension. Plested et al. 1999. The quality of life in chronic illness can vary with age, especially for senior adults. Though chronic conditions affect patients of all ages and sex, seniors' mobility and consequently their physical and functional status, emotional balance, and self-esteem decline because of their dependence on others, which in turn contribute to the reduction in the quality of life for seniors suffering from lifestyle diseases. Many studies have shown consistently negative relationship between multiple chronic diseases and quality of life. The presence of chronic illness is related to unhappiness and psychological distress resulting in low quality of life for both men and women. Osterk et al. 2011 found no association between chronic disease and physical mobility, functional independent activities, and type of chronic condition in either gender. Despite these inconsistent findings, degenerative disease will have a significant influence on quality of life. Carvalho et al. 2013 evaluated HRQoL in hypertensive patients and compared it with that of normotensive individuals and concluded that those with high BP had worse HRQoL. Behavioral risk factors such as smoking and alcohol abuse are another important modifiable risk factors which decreases the quality of life. Empirical studies clearly show that alcohol and smoking habits have negative consequences for health-related quality of life by reducing life expectancy and resulting in psychological problems. Fogel et al. 2012. Most of the available studies related to chronic diseases and lifestyle behaviors have been conducted in developed countries, and very less is known about the influence of lifestyle factors including smoking and alcohol drinking and chronic illness on the quality of life in developing countries. Much more research is required to be directed in this field to understand the pathogenesis of lifestyle diseases. Chronic life-threatening and disabling conditions introduce significant psychosocial stressors which reduces the quality of life of patients suffering from lifestyle diseases. Awareness is also an important factor in reducing the effect of lifestyle diseases. Hypertension and diabetes are two common conditions which in recent times have new extended definition to include so-called pre-hypertension and pre-diabetic state, wherein this gives an individual a warning period before the onset of the disease for intervention in terms of physical activity or lifestyle modifications. But sometimes awareness may play a negative role, at least for hypertension. Those aware of their hypertension status have been found to have a lower HRQoL than those who were unaware of it. That is, there is a labeling effect. Mena, Martin et al. 2000. Prevention and control of lifestyle diseases. Lifestyle disease rates are already higher than expected in many countries. Consequently, these patients are making significant demand on the health services of a country, of a nation. Appropriate planning to manage lifestyle disease and their risk factor is of paramount importance. Most of the risk factors emerge as a result of an unhealthy lifestyle that is followed for several decades. The risk factors have a synergistic effect on the total chronic disease risk. Health services planned for prevention and care must therefore take cognizance of the burden of multiple chronic disease risk factors in the same patient. Although a wide range of cost-effective primary and secondary prevention strategies are available, their coverage is generally low, especially in poor and rural populations. Much of the care for chronic disease is provided in the private sector and can be very expensive. Sufficient evidence exists to warrant immediate action to scale up interventions for chronic diseases, though private and public sector improved public health and primary health care system and essential for the implementation of cost-effective interventions. Another important way to control lifestyle disease is to focus on reducing the risk factors associated with these diseases. To lessen the impact of NCDs on individual and society, a comprehensive approach is needed requiring all sectors including health, finance, transport, education, agriculture, planning and others to collaborate to reduce the risk associated with NCDs and promote interventions to prevent and control them. Investing in better management of NCDs is critical. Management of NCD include detecting, screening and treating these diseases and providing access to palliative care for people in need. High impact essential NCD intervention can be delivered through a primary health care approach to strengthen early detection and timely treatment. Evidence show such intervention are excellent economic investment because if provided early to patients, they can reduce the need for more expensive treatment. Countries with inadequate health insurance coverage are unlikely to provide universal access to essential NCD interventions. NCD management interventions are essential for achieving the global target of a 25% relative reduction in the risk of premature mortality from NCDs by 2025 and the Sustainable Development of Goals SDG target of a 1/3 reduction in premature deaths from NCDs by 2030. The WHO report focuses on the need to move away from the actual model of care of efficiently coordinated and patient-centered care. Such a move needs to facilitate an ongoing relationship between providers and patients and help patients to make full use of their own and their community's resources. Holman and Lorig 2000, Wagner 2000. The partnership between the patient and the healthcare provider is not just a resource for understanding ill health. It is the basis for the prevention and management of chronic diseases and their risk factors. Swartz and Dick 2002. Therefore, the approach of healthcare prevention and management should focus on the patient's own social setting and context, cultural beliefs and practices. Above all, physical activity and dietary modifications are purportedly identified as the cornerstones of management of overweight obesity. Overall encouragement of healthy lifestyle in the population should help to reduce the high burden of lifestyle diseases and metabolic syndrome MS in India. Government and non-government agencies of the country should work together to achieve this goal. Lifestyle intervention have shown definite benefits in the management and prevention of lifestyle disease in large-scale studies. Initiatives taken by WHO to prevent lifestyle diseases. WHO 2017, Walk the Talk. WHO Healthy Workplace Initiative. The Walk the Talk, a WHO Health Workplace Initiative, was launched at WHO headquarters at Geneva and regional offices on the 19th January 2016. The initiative aims to promote healthy lifestyle in the workplace and reflects the commitment of WHO staff to set an example by following the recommendations set forward to member states. A comprehensive strategy for a healthy workplace addresses a broad range of health issues, including physical activity, occupational health and safety, and nutrition. The initiative is taken forward by the Staff Health, Safety and Wellbeing SHSW Committee. Step Up Campaign. The main stairways of WHO headquarters as well as various regional offices were decorated with a series of motivational messages. This colorful and exciting campaign promoted the use of stairs as part of the sustained commitment by the staff to increase physical activity at workplace. This campaign was followed up with 3 surveys assessing stairway usage. The results from the latest survey showed that stairways usage has increased from the period before the campaign had launched, while use of elevators has decreased. An example of the stairway message campaign is shown below. Global Corporate Challenge 2016 GCC. The Global Corporate Challenge began on 25th May 2016. WHO had 1295 participants, amounting to 185 teams globally. Staff participants at WHO managed to walk a daily average of 1300 steps, which totaled to 1.5 billion steps or 96000 kilometers. Staff participants also managed to total combined weight loss of greater than 1000 kg. At the conclusion of this successful challenge, participants described increased productivity, improved sleep, and greater adherence to healthier nutritional choices. Walk the Talk monthly runs and guided walks. WHO headquarters and regional offices have also committed to undertaking a series of monthly runs and guided walks. This initiative provides a productive break from the office, an opportunity to strengthen social ties amongst the colleagues and promote community well-being, promoting healthy diet choice at the workplace. WHO has published sugar guidelines and provides technical assistance to member states in the design of policies to promote healthy diet choice. In accordance with its guideline, WHO has replaced sugar-sweetened beverages, including fruit juices, in their restaurants with vending machines with healthier alternatives. There are plans in the future to label the nutritional value of snacks and meals available for purchase across the workplace. Summarize this module. Poor lifestyle choice such as smoking, overuse of alcohol, poor diet, lack of physical activity, and inadequate relief of chronic stress are key contributors in the development and progression of preventable lifestyle diseases, including obesity, type 2 disease, mellitus, hypertension, cardiovascular disease, and several types of cancer. Even though doctors encourage healthy behavior to help prevent or manage many chronic medical conditions, many patients are inadequately prepared to either start or maintain these appropriate healthy changes. Most patients understand the reasoning behind a healthy lifestyle even if they do not understand the disease processes. They can occur when they do not maintain healthy habits. Despite an understanding of what constitutes a healthy lifestyle, many patients lack the behavioral skill they need to apply every day to sustain these good habits. Healthy lifestyle modification interventions include nutritional counseling, exercise training, and stress management techniques to improve outcome for patients at risk and those who already have common chronic diseases. Anthropological studies show that adults with common chronic conditions who participates in comprehensive lifestyle modification program experience rapid, significant, clinically meaningful and sustainable improvement in the overall health outcomes. It may be recommended that in addition to the preventive actions required to reduce the risk factors of lifestyle diseases, health services should diagnose and control hypertension and diabetes and should ensure access to knowledge about healthy living and the development of affordable clinical care. It may also be emphasized that there is a need to build a niche to conduct research and development activities and to develop institutional frameworks. This would facilitate the development of lifestyle disease prevention activities by advocating healthy lifestyle for healthy quality of life and the transformation of the healthcare services to adequately cope with the enormous, mostly unacknowledged burden of lifestyle diseases. Regular physical activity reduces the risk and symptom of many lifestyle diseases. Therefore, modification of lifestyles for a healthy living increase quality of life. Thank you.